Hello. During the panopto or echo recording of lecture number 2 on the humerus and clavicle, the sound was cut out for about the first 5 or 10 minutes. So the purpose of this recording here is just to make sure there are no gaps in students' potential knowledge when they are reviewing their lecture material. So we're going to be talking about just the first few slides of the humerus and clavicle lecture. First of all, let's have a look at the anatomy of the humerus and the clavicle. When we consider the humerus, it's important to consider it almost in three components. That is the shoulder component, the elbow component, and the midshaft, if you like. We'll be considering the proximal humerus, and most particularly the glenohumeral articulation, in lecture number 3 when we look at the actual shoulder girdle. Your studies of the distal part of the humerus, and most particularly the elbow, have been undertaken in year 1, and that material won't be assessed unless we have expanded upon that material significantly, as is the case when we were discussing supracondylar fractures in the tutorial. So let's talk about the humerus, focusing on the midpoint and a little touch of the proximal humerus. It's important to know that the humerus has tubercles or tuberosities rather than trochanters, which are the case with the femora. And most particularly, the humerus has got two recognized necks to it: the anatomical neck and the surgical neck. The anatomical neck is immediately below the humeral head, and that anatomical neck is most correctly named, but it's not an area that breaks very often. However, there is a thinner segment underneath that greater and lesser tubercle, which does have a tendency to fracture more commonly. That is the patient. The clavicle is quite a simple bone. It is a slightly curved, slightly S-shaped rod of bone. When we see the clavicle on an X-ray, it should be not foreshortened. It should be shown fairly as a nice elongated structure. Generally speaking, if you can see the curvature is quite a marked curvature in the clavicle, it generally means the structure's been foreshortened. Otherwise, it's a very, very simple structure. It's a slightly curved rod of bone which has an articulation medially with the sternum and laterally with the acromion. Surface anatomy. The surface anatomy of the shoulder, let's start off with the anterior structures. The most useful things to be able to palpate are the clavicle. Clavicle should be able to be palpated throughout almost the entirety of its length. You should be able to almost, if not definitely, palpate it all the way up to and including the acromion. You should be able to palpate the patient's greater tuberosity. Depending upon patient compliance, the tuberosity can often be most readily identified by having your hand cupped over the humeral head and by internally and externally rotating the humerus, and that greater tuberosity will bulge out in more of an external rotation mechanism. Moving more medially, you have got the sternal end of the clavicle, and so you should be able to probably palpate the sternoclavicular joint, but more particularly you should be able to palpate the patient's jugular notch very, very readily. Posteriorly, the scapula should be able to be palpated inferiorly, a little touch laterally, but more particularly the medial aspect should be able to be palpated almost along its entire length. Of course, the humeral shaft should be able to be, if not directly palpated, then at least have a good understanding of where it lies relative to the soft tissue contours. And we can see there a diagram of the anterior and posterior parts of the surface anatomy. So let's talk about the routine projections of the humerus. The humerus should be undertaken at a 1 metre FFD, unless the patient has particularly long humeri, in which case you can increase your FFD to compensate and try to get a little less magnification. The humerus is a body region where different people will tell you different things about whether or not it requires a grid. I tend to use a grid because it can be a little bit variable, and I think that you do get better resolution. But it is one of those body regions sort of on the cusp of needing a grid or not. I have a tendency to tell my patients to stay very still, just take a little breath in and hold it, just because that taking of a breath reinforces the need for them to stay nice and still. Now, the humerus projection, you can see this image in front of you shows the particular patient with an external rotation of the arm, and that is the ideal textbook position of the AP humerus. However, in a clinical examination, I'd like for you to have a look at your patient, talk to your patient, examine your patient, and find out whether or not it's appropriate to externally rotate the arm like that. If you have a suspicion that the patient has a humeral fracture, often the most appropriate practice is just a neutral position. Whatever the patient is currently in and is comfortable in maintaining is often a good first survey image to see what images do lie in there, what injuries do lie in there, I should say. So ideally the patient will have their arm externally rotated such that their humeral epicondyles are equidistant to the plane of the film, and you should be able to palpate those to make sure that they are equidistant. It's a straight tube examination that is perpendicular to the image receptor and to the anatomy. And ideally what you should do is to rotate your light beam diaphragm so that the collimation is parallel with the long axis of the humerus. That way you can get some nice tighter collimation. Now the image receptor I've written down here is 35 by 43 portrait, and that's true. That assumes that the patient's arm is, as you can see in that image in front of you there, a reasonably vertical diagonal. If the patient's arm had been abducted more, then it might be more appropriate to do a 35 by 43 landscape image receptor. It really does depend on patient compliance. Generally speaking, the arm's going to be a reasonably vertical structure, so 35 by 43 portrait, use the entire length of the diagonal of the 35 by 43, and you should be able to get it on for the majority of people. And what should it look like? Well, the main criteria is that you should be able to see those humeral epicondyles maximally. It shouldn't be rotated from a true AP position. If you are undertaking a true AP position, some of these criteria just aren't valid if the patient's arm has been put in a neutral position for patient comfort or for unknown injury extent. So the greater tubercle should be in profile. You should include the entirety of the humerus, and 95% of patients you should be able to include all of the humerus on one projection. And you should have markers there to indicate if the patient's had a specific rotation other than what would be expected. And otherwise, window and level should be appropriate for that humerus. Now the lateral. The position that you can see in front of you there is very, very similar to the AP, but essentially the entirety of the arm has been rotated into a lateral position. Now that looks quite uncomfortable for the patient, and indeed is a fairly uncomfortable position. It's quite hard to maintain that position, and you'll notice that while the patient's elbow is close to the image receptor, the patient's shoulder by necessity is being pushed away. It's actually very, very uncomfortable to try to push your shoulder backwards to get in contact with the image receptor there as well. So the criteria or the positioning of a lateral humerus is as from the previous projection, but with condyles superimposed. So you should be palpating those humeral epicondyles to make sure they are superimposed, but it can be a very, very difficult projection to do. Now that lateral projection can be done with the patient's back against the board. However, depending upon the patient's habitus, their posture, their compliance, it might be more comfortable to actually do these with the patient in a PA position with their chest against the board, and that can often facilitate getting the plane of that humerus even closer into the image receptor. In addition, when you have got a patient who might have a hyposthenic body habitus, it can be challenging to get a good exposure that for the entirety of the humerus in that lateral position. In that circumstance, it might be necessary to do an elbow up projection. and then to do a lateral shoulder projection, which we will recognize as the lateral scapular projection, which we'll be discussing in lecture number 3. Finally, on this photograph in front of you here, you can see that the light beam diaphragm is a vertical structure there. I wouldn't do it like that. I would be rotating it such that I can collimate quite closely into the humeral borders. And as before, 35 by 43 portrait, that might be turned landscape if the arm is greatly abducted, but that will be on a case-by-case basis for the patient. Here's a nicely performed lateral humerus, and we can see that the humeral epicondyles are close to superimposed. Because of the divergent ray and the fact that we're centered on the midshaft of the humerus, it's often the case that the humeral epicondyles won't be completely superimposed, and that's entirely fine. If we wanted to see that elbow joint completely in profile, we would take a specific lateral elbow projection. You can see on this particular image the soft tissue border near the shoulder, and if this patient had a lot of soft tissue over that shoulder region, that's when we might do a lateral scapular projection as a secondary view to show the proximal portions of the humerus. Just a couple of quick notes on that humerus projection. Obviously, number one, if there is a suspicion of a fracture, don't rotate the arm. Just take your first view as close as you can to an AP projection, utilizing beam angulations if need be, but don't internally or externally rotate the arm because there is a good chance of vascular compromise. One projection which can be quite handy is what I think of as the Arnie projection. This one doesn't have a name in a textbook, but it's basically a way of performing a lateral humerus for a patient who is supine. Often, if you can get the patient in a position like this, their arm will be in a true lateral position, and you can actually achieve it quite readily. So there's no reason why it has to necessarily be a lateromedial lateral. It can be mediolateral, so just be prepared to think laterally. And finally, elbows are fairly vulnerable structures, okay, so please be aware that the distal part of the humerus, particularly with pediatrics and supracondylar fractures, can be a vulnerable area. Okay, so those are the slides which were missing in the Panopto or Echo recording from your notes. For the rest of this presentation, I encourage you to go and have a look at the recordings online, and if you have any questions, please jump onto the discussion board on Blackboard or send me an email. Thanks, and I'll see you in class.